Hello everyone, I am myself Dr. Rajesh Gubba. I am the general medicine educator. In this session, I'll be discussing a very important topic, that is the complications of the diabetes mellitus. So let me just do a quick recap of these complications. So first you need to know that in diabetes mellitus we have macrovascular complications and then microvascular complications. So what are the macrovascular complications? First important macrovascular complication include the coronary artery disease. Then next we have the cerebrovascular accidents, then the peripheral arterial disease. So these are the macrovascular complications. Then followed by that, what are the microvascular complications? The microvascular complications of diabetes are number one, diabetic nephropathy, diabetic neuropathy, and then the diabetic retinopathy. So these are the microvascular complications of the diabetes mellitus. Now you have to remember that the development of these microvascular complications or macrovascular complications completely depends upon the effect of the glycemic control, right? So if the glycemic control of the individual is good, then micro or macrovascular complications can be stopped. So glycemic control is very important in diabetes mellitus. Then what is the most common cause of death in patients with the diabetes mellitus? So please remember, the most common cause of death will be the cardiovascular diseases. Now what will be that cardiovascular diseases? That cardiovascular diseases, it includes the myocardial infarction and as well as the development of congestive heart failure. This will be the most common cause of death in patients with the diabetes mellitus. Now you need to know what is the indication of the coronary artery bypass graft in the diabetic patients. See, in a normal individual, you require a triple vessel disease for the coronary artery bypass graft to be done. But in diabetic patients, please remember, even there is presence of a two vessel disease, then you have to take the patient for the coronary artery bypass graft. Then the next important thing is, what is the central pathological mechanism in the development of macrovascular disease? The central pathological mechanism is the atherosclerosis, that is accumulation of the fat within the vessel wall, and that will cause narrowing of the arterial wall throughout the body, and that will be responsible for the development of macrovascular diseases like peripheral arterial disease, coronary artery disease, and then the cerebrovascular accidents. And the next important question is, because it is the dyslipidemia which will be causing the atherosclerosis, how frequently lipid testing is done in diabetes mellitus? So please remember, annually the lipid testing has to be done in diabetic patients, right? So this is a very, very important investigation that you have to do in diabetics. Next, now, okay, you have done the lipid testing. What should be the lipid goals in diabetes mellitus? So we have the LDL cholesterol. The lipid goal should be less than 100 milligrams per deciliter. But if the individual has overt cardiovascular disease, then the lipid goal of LDL is just only less than 70 milligrams per deciliter. Whereas high density lipid, if you see, it should be more than 50 milligrams per deciliter, and triglycerides, it should be less than 150 milligrams per deciliter. So this will be the lipid goals in diabetes mellitus. Then followed by that, how do you manage if there is development of dyslipidemia in diabetic patients? So first and foremost, the lifestyle modification, that is diet and as well as exercise, is very important stay of treatment in dyslipidemia in diabetics. Not only diabetics, in any forms of dyslipidemia, diet and exercise or lifestyle modification is very important. Then along with that, the drug therapy. And what is the drug therapy that you have to give? That is statin. So along with lifestyle modification, please remember, you also need to give statin. That is a very important part of the treatment. Next, now the question is the microvascular complications. Microvascular complications, I have taught you, that is diabetic nephropathy, diabetic retinopathy, and diabetic neuropathy. So what are the manifestations of the diabetic nephropathy? See, almost like 30 to 40% of type 1 diabetes, they develop diabetic nephropathy. and 20 to 30% of type 2 diabetes mellitus, they develop diabetic nephropathy. Now, what will be the manifestations? The manifestations will be the hyperproliferation, proteinuria, and the development of the end stage renal disease. That will be the manifestation of the diabetic nephropathy. But what will be the earliest manifestation? That will be in the form of proteinuria. And if you don't treat at the level of the proteinuria, the individual will progress to the development of the end stage renal disease. Next. Now, the very important question is, what are the pathological changes that appear in the kidney in diabetic nephropathy? So please remember, in diabetic nephropathy, you have two important changes that will appear in the kidney. Number one, you have diffuse changes in the kidney. Then you have the development of nodular changes within the kidney. So what are those diffuse changes? Let me tell you, the diffuse changes, they are more common than compared to that of the nodular changes. Now, what will be the diffuse changes? That is widening of the glomerular basement membrane and mesangial thickening. That will be the most common change in diffuse glomerulosclerosis. Whereas if you take the nodular pathology can occur and results in hyalinization of the afferent glomerular arterioles. And what will be that nodular lesions called as? That nodular lesions, they are called as the Kimmel-Steels-Wilson syndrome or Kimmel-Steels-Wilson's lesions. And these Kimmel-Steels-Wilson's lesions, let me tell you, they are pathognomic, right? They are pathognomic of the diabetes mellitus or diabetic nephropathy. So, but diffuse changes are more common than compared to that of nodular, and the diffuse changes will be in the form of glomerular basement membrane thickening and mesangial thickening. Next, what is the management of the diabetic nephropathy? So the management of diabetic nephropathy involve strict control of the diabetes mellitus. Then you need to give AC inhibitors, and dialysis or renal transplantation has to be done. So this will be the management of the diabetic nephropathy. Strict control of diabetes, AC inhibitors, and dialysis or the renal transplantation. Now the point is, how frequently are these diabetics screened for proteinuria? Let me tell you, these diabetics, they have to be screened annually for proteinuria. Right, they have to be screened annually for proteinuria, wherein you can detect the development of diabetic nephropathy in the early stages. Next. Now, if there is proteinuria, first important what they develop is microalbuminuria. And you need to know what is microalbuminuria. Microalbuminuria is the excretion of proteins around 30 to 300 milligrams per 24 hours. And if you take the normal albumin that is being excreted in the urine per 24 hours, it will be less than 30 milligrams per 24 hours. This will be the normal quantity of albumin that is being excreted in 24 hours. And when you are using the word microalbuminuria, it is defined as a level 30 to 300 milligrams. And how will you test for the proteinuria? See, the testing of the proteinuria is done on a standard dipstick test, right? It is done on a standard dipstick test. And this particular standard dipstick test can detect the proteinuria when the level of the proteinuria is more than 300 milligrams per 24 hours. So that is about your microalbuminuria. Microalbuminuria is just only 30 to 300. But your dipstick test will detect the proteinuria when the quantity of the proteinuria is more than 300 milligrams per 24 hours. That means your dipstick test does not diagnose the microalbuminuria, right? Next. Now, this is a very important question. That is, what is the drug of choice for the proteinuria? The drug of choice for proteinuria is you need to give ACE inhibitors or the angiotensin receptor blockers. See, these ACE inhibitors or angiotensin receptor blockers, what they do is they will reduce the intraglomerular pressure. Right? They reduce the intraglomerular pressure. So as they reduce the intraglomerular pressure, the proteinuria will be reduced. Okay, so that is about the drug of choice for proteinuria. Now the question is, what is the most common cause of end-stage renal disease? Please remember, the most common cause for end-stage renal disease is diabetes mellitus. We have many other causes for the development of end-stage renal disease, but among all those, the most common cause will be diabetes mellitus. Okay, next. The next important microvascular complication is diabetic retinopathy. The question is, what is the effect of diabetic retinopathy? Let me tell you, as an end effect of diabetic retinopathy, if it is not being detected in early stages, the individual will develop blindness, right? The individual will develop blindness, okay? And the next important point is this diabetic retinopathy, let me tell you, it is of two forms. One is proliferative diabetic retinopathy and the other one is non-proliferative diabetic retinopathy. What is proliferative diabetic retinopathy? Proliferative diabetic retinopathy is that it is defined as the presence of vitreous hemorrhages or the neovascularization. Neovascularization is the new vessel formation, right? Neovascularization is the new vessel formation. So that will be the feature of the proliferative diabetic retinopathy, right? Next, then followed by that, what are the additional features of proliferative diabetic retinopathy? That includes, right, when you do a fundus examination, you will observe the presence of the microaneurysms. You will make out the presence of hemorrhages, exudates, retinal edema. So these are all the abnormal proliferative damages that you will see in the fundus examination of a patient with the proliferative diabetic retinopathy. Then followed by that, how do you treat the proliferative diabetic retinopathy? Let me tell you, the treatment of proliferative diabetic retinopathy is that you need to do laser photocoagulation. That will be the treatment of proliferative diabetic retinopathy. Then next, how do you treat non-proliferative diabetic retinopathy? So let me tell you, for non-proliferative diabetic retinopathy, you don't have any additional treatment strategy. Only thing, a tight control of the glucose level, that will treat your non-proliferative diabetic retinopathy. But let me tell you, both of them can make the individual to develop blindness. So how frequently screening is done for diabetic retinopathy? So please remember, the screening for diabetic retinopathy in type 2 diabetes mellitus, even this, it is also done annually, right? Annually once you have to screen for development of diabetic retinopathy in diabetic patients. Next, and whereas in type 1 diabetes mellitus, so please remember, in type 2, you have to check for diabetic retinopathy at the time of diagnosis itself and then annually. Whereas in type 1 diabetes mellitus, you should not test for diabetic retinopathy at the time of diagnosis, but after 5 years, you need to test for the development of, is there any development of diabetic retinopathy? And later, annually, you need to examine for the development of diabetic retinopathy. So this is how the screening is done for diabetic retinopathy. Next, what is the most common type of peripheral neuropathy in diabetics? The most common type of peripheral neuropathy in diabetics is that they develop symmetrical sensory peripheral neuropathy, right? So peripheral neuropathy here, it is a symmetrical sensory loss where at the periphery. And what will be that symmetrical sensory loss? That will be in the form of numbness, that will be in the form of paresthesia, that will be in the form of pain being prevalent. So these are the features of the peripheral neuropathy, right? And the most common type of peripheral neuropathy is bilateral distal symmetrical sensory loss. That will be the most common form of peripheral neuropathy. Next, what are the physical examination findings in peripheral neuropathy? Let me tell you, your peripheral nerves, they are the lower motor neurons or lower motor nerves. And when there is development of peripheral neuropathy, there will be absent reflexes, right? There will be absent deep tendon reflexes, and there is also loss of the vibratory sense, right? Loss of vibratory sense and absence of deep tendon reflexes. These are the features of the peripheral neuropathy. Next, then followed by that, how frequently you have to examine for the peripheral neuropathy? See, podiatric examination. What do you mean by the word podiatric examination? That is foot examination. So foot examination should occur annually to look for early signs of neuropathy, since it leads to increased injury from the trauma. So annually you have to test for the peripheral neuropathy, and that is called podiatric examination. Now, what is mononeuropathy or mononeuritis multiplex? Even this mononeuropathy or mononeuritis multiplex is also common in diabetes mellitus. Mononeuropathy, it affects a single nerve, right? Single nerve, or it can affect a nerve trunk, that is called mononeuritis multiplex. And this is vascular in origin, that is due to atherosclerosis of the blood vessels supplying the nerves. And these patients, they will have foot drop because of the involvement of the common peroneal nerve. There can be development of wrist drop due to the involvement of the radial nerve. So that is what is your mononeuropathy or mononeuritis multiplex. Then what is the most common cranial nerve affected in diabetes mellitus? The most common cranial nerve which is affected in diabetes mellitus is the third cranial nerve. And what are the other cranial nerves affected? The other cranial nerves which are being affected is the fourth and as well as the sixth cranial nerve. Now, followed by this, what are the features of autonomic neuropathy? Most common type of neuropathy in diabetes, that is distal symmetrical sensory neuropathy, that is peripheral neuropathy. But there can be mononeuropathy or mononeuritis multiplex. There can be involvement of cranial nerve, and there can be development of autonomic neuropathy also. So autonomic neuropathy can be devastating, and these patients, they have development of orthostatic hypotension and syncope. These are the main manifestations of the autonomic neuropathy, right? And apart from that, even gastrointestinal abnormalities. Gastrointestinal abnormalities include difficulty in swallowing. There will be delayed gastric emptying, that is called gastroparesis. And there can be development of constipation or diarrhea. So these will be the gastrointestinal abnormalities that you will see in patients with the diabetes secondary to autonomic neuropathy, right? Next. Now, what is the diagnostic test for gastroparesis? Diagnostic test for gastroparesis will be gastric emptying scintigraphy study. That will be the diagnostic test of choice for gastroparesis. Please remember, it's a very, very important point. Next, what are the genitourinary effects of the autonomic neuropathy? Genitourinary effects include the urinary retention. Right, urinary retention. Why is that? That is due to bladder dysfunction or the bladder paralysis. And there can be also impotency and retrograde ejaculation. And the prevalence of the erectile dysfunction, it is seen in almost 50% in patients with 10 years of diabetes mellitus. So please remember, it's a very, very important point. So genitourinary manifestation will be in the form of urinary retention and impotency, retrograde ejaculation, and erectile dysfunction. Then, so this will be the diabetic foot ulcer, right, which is a macrovascular complication. Then, how do you prevent neuropathy in diabetes mellitus? How do you prevent? Very, very important point. That is, a strict or tight glycemic control will prevent the development of the neuropathy. Then, followed by that, what are the drugs that you will give for the neuropathy? Drugs that you will give for the neuropathy, see that you have to reduce that numbness, tingling, pins and needle sensations, paresthesias. For that, you need to give gabapentin, pregabalin, or amitriptyline and carbamazepine. But out of all these two, gabapentin and as well as pregabalin, they are being considered to be the best drugs. So that is how you have to treat the neuropathy. Next, how do you treat gastroparesis? For gastroparesis, you need to give a prokinetic drug, and that particular prokinetic drug is metoclopramide or erythromycin has to be given. That is how you will treat the gastroparesis. Now, what is the treatment for erectile dysfunction? Because 50% of individuals, they are developing erectile dysfunction. For that, you need to give sildenafil. That will be the drug for erectile dysfunction. And yes, so these are some of the very important points related to the chronic complications of diabetes mellitus. Few more I will discuss in diabetic ketoacidosis. Thank you very much. See you in the next session.